Good evening, everybody. We had a little bit of technical problems, but they're all solved. And as we can see down in the agenda, there's a lot of participants joining. It's already 134 at the moment. Welcome. We're here now. I'm very honored, and I think it's very cool that you're all here again. I think this is the fourth edition of the SECEC user webinar we're organizing. The first one was on rotator cuff. I think the second one was on frozen shoulder, and then we had stiff elbow last year, and this is already the fourth edition. And I'm really looking forward to this because this is the shoulder arthroplasty session. The idea is that everyone who wants to ask questions from all the participants, they can do that via the Q&A session at the agenda at the right button. And then after the four presentations we're getting now on shoulder arthroplasty, the Q&A session will be held and the questions will be answered. I first like to introduce now the first speaker. Is Matthijs Jacksons. He's from basically two countries, from Belgium. But he's working in St. Gallen in Switzerland, and he recently got his PhD through the University of Ghent. So he's really into the topic of arthrosis and cuff tear arthropathy at the moment, at the top of his knowledge. So Matthijs Jackson will give us the first introduction in his first talk. Enjoy.
Good evening, everyone. Welcome to this webinar from my side. My name is Matthijs Jackson, and I'm a consultant in the shoulder and elbow group in St. Gallen in Switzerland. And I'm happy to talk about the etiology and pathogenesis of omarthrosis and cuff tear arthropathy. As you all know, the glenohumeral joint is the joint with the largest range of motion and is a ball and socket joint surrounded with a synovial capsule. And this quasi-spherical ball-shaped humeral head articulates with the cup-like glenoid fossa of the scapula, allowing for 6 degrees of freedom of motion. The orientation of the articular surface of the humeral head is known to be highly variable, with a variable neck shaft angle and a large variability in torsion. And also a wide variety of cartilage thickness on the articular surface of the humeral head has been described, with the thickest portion in the central zone. Similarly, the orientation of the glenoid is highly variable. The articular surface of the glenoid fossa is typically slightly tilted superiorly. And when assessed in the sagittal plane in relation to the scapular body, the glenoid fossa has a small degree of retroversion. In contrast to the humeral head, the articular cartilage of the glenoid is the thinnest in the center. Complex interaction between static and dynamic stabilizers provides crucial stability that is needed to achieve the large range of motion. Cartilage and surrounding labrum create a more conforming joint and distributes joint pressure more evenly. The capsule and ligaments provide a static stabilization. And the rotator cuff muscles provide a dynamic stability. It is the line of pull that is rather important than the exerted moment, as it directs and pushes the humeral head into the glenoid fossa. So to center the humeral head in the glenoid fossa, a balanced force couple of the rotator cuff is necessary. And a force couple is a combination of agonists that exert two parallel forces with identical magnitude in opposite direction, resulting in a balanced force moment which allows for rotation. So in the coronal plane of the shoulder, a force couple can be seen between deltoid and supraspinatus versus inferior rotator cuff. Then the transverse force couple is a balanced moment between anterior and posterior rotator cuff. These force couples are important to provide a fixed fulcrum which allows for elevation or abduction of the humerus. Osteoarthritis, or OA, is characterized by an until now irreversible degeneration of cartilage and subchondral bone, with some degree of synovial inflammation and hypertrophy of the joint capsule. Whereas secondary OA has a clear etiology of the disease, degenerative joint breakdown without a clear etiology is called primary OA. So primary OA is generally considered to be a simple wear and tear of the joint. However, several risk factors such as aging, obesity, repetitive loading, and predisposing genes have been identified. Pathophysiology of primary OA in synovial joints is complex and not fully understood. The compressive and tensile properties of cartilage are mainly attributed to the extracellular matrix. In OA, the dynamic remodeling process to maintain a homeostatic balance between matrix synthesis and degradation is disturbed by an overexpression of degrading inflammatory enzymes and cytokines. As a result, a depletion of inhibitors occurs, and the biomechanical properties of cartilage alter and eventually fail. Minor damage progresses from the surface to deeper layers, resulting in larger eroded zones over time. These eroded zones of cartilage and osteophytes can be macroscopically seen during surgery, both on glenoid side and the humeral side. These degenerative changes can be identified on radiographs based on specific characteristics such as joint space narrowing, cysts, subchondral sclerosis, and osteophytes. In a subgroup, including a substantial part of patients with primary OA, a posterior decentering of the humeral head can be noticed. So this characteristic of humeral head alignment together with glenoid morphology were used to classify the pathoanatomy by Gilles Walsh. So in the original classification, we have type A that is characterized by centered humeral head with centered glenoid erosion. Type B is characterized by a posteriorly decentered humeral head with signs of posterior erosion, and then type C is defined by severe retroversion, not caused by glenohumeral arthritis, but because of a dysplastic type of the glenoid. So both type A and B were further stratified according to the degree of erosion, with type B2 having this typical biconcave glenoid. Then the modified classification, published in 2016, added two subtypes. Type B3 was defined by important posterior humeral head subluxation, but a concave wear pattern of the glenoid due to more severe erosion. And also type D was added to cover the rarely seen type with anterior humeral head decentering. So humeral decentering is a very interesting characteristic and has been studied by many groups. And we also looked at it with our group, and we could identify small but distinct posterior decentering also in type A shoulders, which is the type with the central erosion. Then you have the group of Iannotti that has used serial CT scans in patients with primary OA to better understand the evolution of decentering. In the paper of Walker, they described that some type A1 shoulders can evolve into a B type with decentering of the humeral head. In a subsequent paper, posterior decentering was associated with a fatty infiltration of the teres minor muscle, potentially weakening posterior rotator cuff. So these findings combined with our findings support also the hypothesis that initial humeral head decentering precedes and provokes further pathologic changes of the glenohumeral joint in primary OA. This highlights the potential importance of an imbalance of the force couple with a weakened posterior cuff in primary OA. Sumit Raniga and colleagues have focused on the role of the humeral torsion in primary OA. They found less retrotorsion of the humerus in type B shoulders when compared to normal non-arthritic humeri and type A humeri. And it remains unknown whether this finding is an etiologic factor that potentially leads to the posterior glenoid wear, or this may be simply a compensatory mechanism of the arthritic changes. The same authors have questioned the hypothesis of an imbalanced force couple as the causing factor of subluxation. So they did a volumetric study comparing anterior versus posterior cuff and found no difference regarding volume. They hypothesized that posterior humeral head subluxation with associated eccentric posterior wear and joint medialization causes a slacking of the posterior cuff. So while the volume remained constant, the cross-sectional area in the two-dimensional analysis of the muscle belly increases, potentially depicting more fatty streaks in the cross-sectional area. Or the slacking of the cuff may lead to a disturbance in the length tensioning relationship of the posterior rotator cuff and then causing more fatty infiltration. Now we get to cuff tear arthropathy, or CTA, and this must be seen as a natural evolution of rotator cuff tears. As mentioned before, the rotator cuff pulls the humeral head into the glenoid to a fixed center of rotation, or so-called fulcrum. Then those tears of a substantial size can lead to an unbalanced force couple, resulting in a missing fulcrum. This can lead to superior migration of the humeral head as the deltoid pulls upwards and rotator cuff fails to contract. This because this semi-constrained joint has turned into an unconstrained joint. So the cliniohumeral joint wear occurs as a result from this altered biomechanics, which can eventually lead to a non-functional shoulder. The Hamada classification is a commonly used classification scheme that uses a mechanistic approach to explain the radiographic changes seen with chronic large to massive rotator cuff tears. And the classification highlights the progressive nature of these large to massive rotator cuff tears leading to CTA, and is based on acromial-humeral distance, presence of acetabolization, and finally cliniohumeral arthritis with a possible humeral head collapse. So note that this acetabolization of the acromion can recreate a fulcrum, similar as in the hip joint, which may help in cliniohumeral movement. However, the Hamada classification does not address morphologic changes of the clinoid, so therefore we have the Favart classification that describes these changes of the clinoid according to degree. Since cuff tear arthropathy evolves from cuff tears, it makes sense to talk a bit about cuff tears. So tears can be traumatic or degenerative, and in traumatic tears, a simple fall can already cause an acute tear. The forces and stresses occurring in the rotator cuff during an attempt to cushion a fall can be 3 times the body weight or more, which may locally exceed the tensile strength of the tendon fibers. For degenerative tears, the etiology is likely multifactorial, and several theories are proposed. These theories will be discussed on the next slide. Regarding the incidence, depending on study, we find a quite high incidence of asymptomatic rotator cuff tears increasing with age. So following theories are described to explain the pathophysiology of degenerative tears. Near postulated that impingement of the rotator cuff against the undersurface of the acromion was the primary factor in causing tendon tears. In support to this, Bigliani described these 3 types of acromial shape, with the type 3 associated with rotator cuff tears and 70% in his case series. This, however, would mean that majority of partial tears should be at the bursal site, which is in contrast to our current data. And more supracromial impingement is considered a secondary process to humeral head migration and bony spur formation. Given the increasing incidence of asymptomatic tears by age, raises the question whether rotator cuff degeneration is a pathologic process or should it be seen as a normal aging process. And this is supported by histological studies that found many changes relating to degeneration in tendons. The next theory is the microtrauma theory, in which microtrauma results in partial tendon tears that then develop into full rotator cuff tears. In the rat model, overuse of rotator cuff tendon led to downregulation of TGF-beta1. Also, inflammatory pathways were identified after repetitive microtrauma. So these results of these studies do support the repetitive microtrauma theory and imply the presence of an acute inflammation. Oxidative stress has also been described. It is thought to contribute to tissue degeneration through the activation of an apoptic pathway. In addition, it has been shown to induce cuff degeneration by activation of enzymes leading to extracellular matrix degradation. Regarding vascular changes, some controversies exist. The traditional belief was that a hypovascular zone exists around the insertion, which would make the area more prone to tears. However, histological data shows in majority of studies hypervascular tissue around the cuff tear site. Although the pathophysiological theories are not conclusive, some clear risk factors have been described, making specific subgroups of populations susceptible for cuff tears. Apart from the obvious aging factor, the remaining factors include female gender, hand dominance, diabetes, obesity, hypertension, smoking, and predisposing genes. So to conclude, for primary OA, we have an unclear etiology, but the pathophysiology seems to be an inflammatory process with the degradation of cartilage with an ineffective effort at repair. We see this distinct pathoanatomical subtypes and anatomical differences that are associated with this feature of humeral decentering. Regarding cuff tear arthropathy, we have an natural evolution of rotator cuff tears. proximal migration or as a result of force couple imbalance can be seen in this pathology, with the pathophysiology of cuff tears likely being multifactorial. We have these specific subgroups of the population that are likely more susceptible for cuff tears. So thank you very much for your attention.
Well, thank you very much, Matthijs. That was a very thorough explanation and very interesting. I also learned a few things again. The next speaker will be very happy that he could join us. He's Sven Lichtenberg from Germany, and he has already gained a lot of knowledge, difficult English words, on the stemless shoulder arthroplasty, which is a new revolution in shoulder arthroplasty land. So Sven will enlighten us all about the stemless shoulder arthroplasty, please.
Dear ladies and gentlemen, dear Chaco, thank you for the opportunity to talk on my experience with the stemless and total shoulder, and to answer the question, does it work or does it not work? These are my disclosures. Why would we go stemless? What was the basic idea? So if you have to deal with fracture sequelae after proximal humeral fractures, you might face very distorted anatomy. You might have sclerotic bone and a relative malpositioning of the tuberosities. And therefore, osteotomies might be necessary. And we know from studies out of France that osteotomies usually end up with bad results, or you would go for a smaller implant and position that in a valgus position. On the other hand, shafted total shoulder arthroplasty causes by load transfer, bone resorption, osteolysis, remodeling, aseptic loosening, and there's always the risk of periprostatic fractures. So the solution would be that you come up with an implant that has direct contact to the cut surface, the metaphyseal bone, and that would give adequate fixation with a stable longevity. Osteointegration is the goal, meaning contact between bone and the implant surface, and with increased porosity with an osteoconductive material like calcium phosphate or HA to increase and promote ingrowth. So the goal of stemless prosthesis was reconstructing the center of rotation independent from the shaft axis to preserve as much bone of the humeral shaft as possible, and again to reconstruct the humeral head anatomically. And with cutting the humeral head also, we would have good and better access to the glenoid to replace it. So in 2004, Zimmer started with the TESS stemless arthroplasty, and then in 2005, the Eclipse came to the market, and after that, pretty much all competitors on the market have introduced stemless prostheses. Pretty much all of them are the same, except for the Eclipse, which has a central screw. All the others have wings or posts and so on, pegs that go into the metaphyseal bone. So does it work? So we have to look at outcomes. And if we look at clinical outcomes, right now, I think this is one of the studies with the longest follow-up, 9 years. We can see that the constant score relative and absolute points, pain, ADL, range of motion, increase significantly from the pre to the post-op status. This is pretty similar to all the other implants like stemmed or short stems on the market. So we also have to look at more details like radiologic results. But first of all, again, this meta-analysis favors the stemless prosthesis over stem prosthesis. If you look at the relative constant score, and again, if you look at range of motion post-operatively, it slightly favors the stemless arthroplasty. And again, one meta-analysis that was published lately, also with one author that we know, favors the stemless prosthesis over stemmed prosthesis. But looking radiologically, does it restore anatomy better than the stemmed prosthesis? And the study of 229 patients, 140 stemless arthroplasties, could show that the shift of center of rotation is significantly less in the stemless arthroplasty. And again, the neck shaft angle is significantly lower in the stem prosthesis. And if we look at the outliers, meaning more than 2 or more than 4 millimeters away from the anatomic center of rotation, again, the stemless performs significantly better than the stem prosthesis. The direction of shift of the center of rotation is pretty much the same, but again, restoring humeral head anatomy in terms of thickness and diameter, the stemless again scores much better. Why would we go stemless? The risk of secondary rotator failure is definitely one, because you might end up with disastrous and very heavy surgical revision surgeries, like you can see in these examples. And again, the long stems have a terrible risk of periprosthetic fractures, and that ends up with a very tough surgery. So with the stemless prosthesis, even if you have a periprosthetic fracture, you can treat it like a normal proximal humeral fracture by just doing an internal fixation. When we do not use the stemless that would be in bad bone and in the proximal humerus, especially like in rheumatoid arthritic patients on osteoporotic bone, or if you have a loss of the calca humeri after fracture. So in 6.6%, that was in the early stages, we had to change our strategy. Nowadays, we pretty much know that stemless works in a lot of situations. So the advantages are you have the least bone loss with this implant. They are easy to revise. We have proven good midterm, long-term fixation. OR time, blood loss is significantly reduced in contrast to stem prosthesis, and it is independent from the given anatomy. So we can restore the center of rotation easily and much better, and the risk of a periprosthetic fracture is not that disastrous. Disadvantages, of course, you need good bone, and maybe it's too easy, so maybe a lot of unexperienced surgeons are tempted to use the implant and then do not do it correctly. So that, in my eyes, could be a risk. So my way nowadays, if I want to do an anatomic total shoulder, I definitely go stemless, and only in the situation of bad bone, then I would go for a short stem, which is convertible, which I can then convert into a reverse arthroplasty. So if you ask me again, does it work? Yes, it does. And it definitely works very best in my hands. So thank you very much for your attention.
Very nice, Sven. Thank you very much. Good remark. Obviously, it works the best in your hands. I like that one. Just the next speaker, but I want to have another comment for all the participants. If you do have questions, please put them in the Q&A session, or maybe via the chat, and then they can be addressed at the end of the Q&A session of this session. Just a short reminder. The next speaker will be Olivier Verborgt. We're going to Belgium, to Antwerp. Olivier and I know each other a long time, and he's been already busy for a long time with PSI and 3D printing and adjusting the glenoid, and how to optimally place anatomical prosthesis. So I'm very happy that he was willing to join us again also tonight. And he will talk on PSI and 3D reconstruction. Please.
So good evening, everyone, and thanks for joining this joint webinar with EUSSER and SECEC on shoulder arthroplasty. So why are we interested in new technology for our shoulder replacements? When we look at the 10-year survival rates of anatomical total shoulder arthroplasty, this is about 92%. However, 10% of our patients remains dissatisfied with their result, and this lies somewhere in between total knee arthroplasty with 20% and total hip arthroplasty with patients, less than 5% of the patients being dissatisfied with the final outcome. So therefore, we need to continue to implement technology to improve surgeon control variables. One of the most important challenges in anatomical arthroplasty is glenoid deformity. And as we heard from the first speaker, in primary osteoarthritis, the glenoid tends to wear out posteriorly. And sometimes this results in really difficult deformities in rather young patients. In order to restore the joint alignment and to restore the cuff balance, it's important to correct that glenoid deformity. Otherwise, you will end up with a prosthesis that looks like this, where the humeral head is subluxed posteriorly, just as the native humeral head was preoperatively. In standard techniques, shoulder surgeons tend to plan and execute this type of deformity looking at standard X-rays and CT scans and try to determine how the glenoid fold can be corrected and what type of implant can be positioned in the right position. At the time of the surgery, standard instrumentation then is used to place a central pin that will further guide the preparation and the reaming of that deformed glenoid, and finally also the implant position. Unfortunately, this has been shown that this standard technique is not resulting always in the best results, going up to 10% of errors or 10 degrees of errors and quite a bit of outliers. Also, on the humeral side, the humeral deformity can be a big challenge when using just simple standard X-ray or CT scans and standard instrumentation. In 2015 already, it has been shown that just the use of 2D imaging and no templating results in too many outliers, and that 3D imaging and templating results in better accuracy and surgeons that are better prepared to go to the operating theater. Since then, 3D planning has been used by quite a bit of surgeons already, looking at the native glenoids, the native bony deformity on the humeral side, but also on the glenoid side. On the humeral side, surgeons can now virtually plan their implants. They can plan their osteotomy, the size of the head, the position of the humeral head, so that the perfect anatomic situation can be planned. Also on the glenoid side, as you can see here, 100% contact of a glenoid component is important in order to get the right results. And then finally, even impingement-free range of motion can be virtually planned when using this type of 3D planning. So this brings a complete different preparation for the shoulder surgeon to his practice when he goes to his operating theater and is planning for a shoulder arthroplasty. So how can that 3D planning help in practice? And this is a patient of mine who is very young, 42-year-old, with a very important and severe osteoarthritis, a primary osteoarthritis with an intact cuff, with pain. Active elevation is still okay, but the patient is very limited in active and passive rotations. The subscap, supraspinatus, and infraspinatus are intact and have good strength. This is the CT scan that he brought already in 2019 with an important glenoid deformity in a posterior wear. Just because he's so young, it was decided not to go for surgery immediately. But 3 years later, he got more pain, dysfunction, and the glenoid deformity got worse. When you take this deformity to a 3D planner, the surgeon now can analyze deformity better. You can see it's a big retroversion of more than 30 degrees. And if the surgeon wants to implant an anatomical prosthesis and correct for the bad retroversion, you can see he has to take away quite a bit of bone. And this is in an anatomic prosthesis unacceptably high. Up to 2 centimeters removal of bone on the glenoids will give him a problem of stability and not the best results. If the patient would have been older, a reverse arthroplasty with an augmented base plate, of course, could have been the right option. But again, this patient is 42-year-old and way too young for a reverse arthroplasty. But in the end, the surgeon was now able to virtually plan his surgery and see what would happen in which case, and then take that planning to the operating room. This is the perioperative image of the humeral head, and this is clear, but also the glenoid, as you can see, is a huge problem with a lot of retroversion, a lot of dysplasia. And the final decision during the surgery was made just to go for a hemiarthroplasty. The humeral head was removed and replaced in an anatomical fashion and reduced with a good stable fixation and stable position. This is the final result of this patient 1 year later. He's happy. He has a hemiarthroplasty because he's so young and he still has a future in the next coming years. And maybe later on a revision to a reverse arthroplasty when he's old enough. Here's another example of a patient that can benefit from 3D planning. He's a 62-year-old left-hand dominant patient with primary osteoarthritis. On the MRI, we can see that the cuff is intact. There's some atrophy, but the tendon is still okay. And in supraspinatus, but also the infraspinatus and the subscap seem to be intact enough to go for an anatomical replacement. However, the glenoid is also worn out, and this is, like we already said, sometimes problematic. And again, the CT scan can be brought to a 3D planning, and here the surgeon can analyze the native bone. You can see if correction is possible to a more anatomical situation using anatomical implant. And in contrast with the previous case, we can see here that it's perfectly doable to implant an anatomical glenoid component, reducing the retroversion from 13 degrees to somewhere between 0 and -10 degrees, which is more acceptable for a final situation. Now, in order to execute that preoperative virtual plan, the surgeon can also use patient-specific instrumentations. These are guides that are printed, 3D printed, and are available for the surgeon during the surgery to finally execute exactly what he has planned preoperatively. This is the first guide that helps to find the central axis of the glenoid, and then in the second patient-specific guide helps the surgeon to correct the deformity using a reamer that helps him exactly take away the bone that he preoperatively measured. And this is much more accurate, of course, than just standard instrumentation, where the surgeon needs to eyeball his correction. This is that same patient 1 year later with an excellent result in an anatomical situation where the deformity was corrected to something that was more acceptable, but still without compromising the bone stock. So how can technology help? We have seen that standard instrumentation brings up to 10 degrees of errors. that patient-specific instrumentation now is there to help surgeons, and this reduces the error below 5 degrees. And the next speaker will talk about augmented reality and navigation, which is the new promising kid on the block. And of course, robotics are just around the corner. We have seen in so many other fields that robotics are so more performing than humans and are so much more accurate in the things that they do that we expect that sooner or later, probably very soon, robotics will be there to help the surgeon to make a better shoulder replacement. Thank you very much, and I hope you can enjoy the rest of this webinar. I hope to see you soon next year in April for our Antwerp shoulder and elbow arthroplasty course that is usually dedicated for surgeons and physiotherapists. And then finally, of course, to see you all back in Munich for the next SECEC Congress.
Thank you very much, Olivier. Wonderful videos as well. Really enjoyed those. And thanks for explaining us how you can correct all those deformities in a very precise way. Since this is a combined SECEC user meeting, we're now going to hear a presentation of Anke Klaas. She's also from Antwerp, so we stay a little longer in Belgium. She's unfortunately not live with us here, but she shared her presentation, and she will enlighten us on the rehab after an anatomical shoulder prosthesis. Yes, please.
Hi, and welcome. First, I would like to thank the organization of this webinar for giving me the opportunity to give this talk. I hope you will find it interesting and refreshing. My name is Anke Klaas. I'm a doctoral researcher at the University of Antwerp in Belgium. My doctoral thesis, with guidance of Professor Verborgt and Professor Struijf, is about possible prognostic or influencing factors in the rehabilitation after total shoulder arthroplasty. Today, I will talk about the rehabilitation after specifically anatomic total shoulder arthroplasties. Do we know how this rehabilitation should go? Is there enough evidence to make a decision? I would like to talk about the when, the what, and the how. Earlier this year, the Federatie Medisch Specialisten in the Netherlands published new guidelines based on the literature. They distinguished two phases in the rehabilitation after anatomic total shoulder arthroplasty. On the one hand, we have the clinical phase in the hospital, short after the surgery, and the post-clinical phase, everything that follows. Another interesting study from Payne et al. From 2016 distinguishes three different phases: the protective, middle, and functional phase. When placing an anatomic total shoulder arthroplasty in Belgium and the Netherlands, usually a deltopectoral incision is used. To gain insight in the joint, the subscapularis tendon is cut and reattached before closing. Due to this reattachment, it is extremely necessary that the surgical report is shared with all healthcare providers. And due to this attachment, some movement should be avoided. Hospital stay length is shortening. Patients after various orthopedic surgeries are discharged early. It seems that early discharges not cause more complications postoperatively, and next to this, there are some clues that it leads to better patient satisfaction. The care that is normally given in the clinical setting is taken care of by primary care. And again, the information about the surgical report are essential information for the physiotherapist that is treating the patient. Preoperative shoulder function, if available, is also very useful information. In this clinical setting, the physiotherapist primary has a coaching task. The main goal now is to guide the patient in the slingwear and give information about the safe zone and adjustment in daily activities. The safe zone is determined by the orthopedic surgeon, depending on the position in which the subscapularis tendon and maybe other tendons are reattached. The transfer between the clinical setting and the physiotherapist has to happen smooth and with as much information as possible. This is the way we can help the patient the best. In Belgium and the Netherlands, the sling wear depends on the orthopedic team. There are some studies that look into delayed or early mobilization. The reattachment of the subscapularis tendon plays a major role. Early mobilization would be beneficial for the mobility of the shoulder joint, while late mobilization would be beneficial for the healing of the subscapularis tendon. In patients with an anatomic shoulder arthroplasty with reattachment of the subscapularis tendon, we see a short positive effect of early mobilization. In this case, early mobilization means passive and active exercises from 1 to 4 weeks postoperative, while late mobilization means a more conservative treatment and only starting with this kind of exercises from 4 to 8 weeks postoperative. Nevertheless, after 12 weeks, this difference diminished. In the early group, more patients showed problems in the reattachment of the subscapularis tendon. This is why they suggest in the guidelines a balance between the early mobilization and immobilization in patients with shoulder arthroplasty with reattachment of the subscapularis. Extreme movements towards external rotation of the shoulder should definitely be avoided. As said before, during the first phase, the physiotherapist has a coaching role. Education is thus extremely necessary. The protective phase usually takes up to 4 to 6 weeks, where we should be really careful with the soft tissue structures that need to be healed. Usually, the patient wears a sling to protect the soft tissues. What are things we can do with our patient except for this education are, for example, auto-assisted movements in the safe zone, mobilizations of the other joints, such as hand, wrist, elbow, and neck, scapulothoracic mobilization, and isometric exercises of the deltoid and posterior cuff. This isometric work should be in less than 20% of the maximally voluntary contraction. Scapulothoracic mobilizations are of great importance. We can expect that the glenohumeral mobility of the shoulder will stay partially limited. The scapulothoracic capability to compensate thus is really important to optimize the movement of the shoulder girdle. In patients with a shoulder arthroplasty, the amount of scapulothoracic movement is more than in patients without a shoulder arthroplasty. Therefore, it is important to start with scapulothoracic work as early as possible in the rehabilitation. The next phase following pain et al. Is the middle phase. The wearing of a sling is not necessary anymore and graded exercises are recommended. It is important that the phases follow the phases of tissue healing and going beyond the safe zone is possible in a graded way. Active exercises against gravity, easy strength work with limited external forces, and supported exercises for trunk balance are all good options. No specific frequency, time, and kind of therapy can be recommended from literature, so rehabilitation individualized per patient seems the best option. Physiotherapists can let them lead by the phase of tissue healing, which can be checked by the reactivity of the tissue, the pain, and the mobility. Then the last phase following pain et al., or still the postclinical phase following the previously named guidelines, is the functional phase, from 3 to 6 months postoperative. But we still see some functional gaining in the months after this. Also here, the most important thing is to focus on the patient and individualize the rehabilitation based on the phases of tissue healing. More functional activities can take place, such as sport-specific work, etc. We try to optimize the strength gain by working with external loads. Best to focus on the activities of daily living and quality of life that go with it to get and keep the patient working. Unfortunately, literature regarding this topic is scarce. 2 systematic reviews are written considering this topic. The one only includes 1 RCT because only 1 exists, and the other one concludes that restoring a range of motion and strength following a shoulder arthroplasty is important. Therefore, I want to make the link with my own research because this is one of the reasons we started the project. In 2019, we started the FINOSA project, Factors Influencing Outcome After Shoulder Arthroplasty, under guidance of Professor Verborgt and Professor Struijf. We saw that guidelines were missing and made a link with influencing factors. When we can determine possible influencing factors during the rehabilitation, we can give this information to the orthopedic surgeons, physiotherapists, and other caregivers, so they can take them into account. It is a longitudinal project where we randomize the patient into 2 groups. We test them clinically on various time points and also ask to fill out several questionnaires to get a broad vision of these patients. I am very happy that we can say that we have the full sample size now of 109 patients, where 43 got an anatomic shoulder arthroplasty and 64 got a reverse total shoulder arthroplasty. We have 33 male patients, 76 female patients. The mean age was 69, and we followed the patients for 24 months. This is a longitudinal project, so we follow the patients for a particular amount of time and see the patient on quite a regular basis. The first contact is preoperative, then we see the patient at 6 weeks, 12 weeks, 6 months, 12 months, and 24 months post-operative. The patients are randomized into 2 groups. The first group has to wear a sling for 4 weeks, an adduction sling, and the other group first start with 4 weeks of abduction sling and then an additional 2 weeks of adduction sling. We test the patients at each visit. Only the 6-week visit is limited to a few range of motion exercises due to safety measures. Preoperatively and all the other postoperative visits, we measure the range of motion in various planes, the isometric muscle strength, and the proprioception. We also ask the patients to fill out following questionnaires. The primary outcome measure is the SPADI for pain and function, to get a clue of their functional and mental state as well. Usually the patient gets to take the questionnaire home and send them back to us when they finish. For now, we have some preliminary results. We filter only the anatomic total shoulder arthroplasty, and as mentioned before, for pain and functionality of the shoulder, we use the SPADI score. This is a score for pain and function on 100. A higher score means more pain and disability, while a lower score means less pain and more functionality. In this graph, we see that that on various time points, the SPADI decreases. First, there is a very steep decrease. After 3 months, this stagnates a little bit, but patients still get better after 1 year, which is remarkable. We have to take into account that how further we go into the follow-up, the less results are available. We are still testing these patients. If we make a distinction between the anatomic and the reverse total shoulder arthroplasties, we see a difference. Anatomic total shoulder arthroplasties were faster in lowering the SPADI score, and they have a better end result. The line for reverse total shoulder arthroplasty is less steep after 3 months than the line for anatomic total arthroplasty. These are the range of motion increases over time. The blue line is the abduction in the scapular plane, the red one is the external rotation, and the green one is the internal rotation. We see that until the final follow-up, there is still an increase in all 3. The mean abduction after 2 years is 146. The mean external rotation, 70 degrees, and the mean internal rotation was 44 degrees. The last 3 graphs is to see if there is an effect of preoperative stiffness or previous surgery on the SPADI score. Here we see that preoperative stiffness for external rotation does affect the slope for SPADI score. We see that both slopes definitely not the same, but it does not affect the end result. So at the end, there is no difference. We see the same for preoperative stiffness for internal rotation. In this case, it does not affect the end result, but it affects the recovery SPADI score. And again, the same is seen for previous surgery. We see that the slope is affected by whether or not the patient did undergo previous surgery, but this did not affect the end score at 2 years follow-up. We have to be cautious when we are interpreting these results. At every time point, less measurements were taken. These will take place in the future. Next to this was the first time we looked into these results. These are preliminary. I've drawn some take-home messages for you. The most important thing is to remember that there are no scientific guidelines for the postoperative rehabilitation after shoulder arthroplasty, and the literature is scarce. This is why we conducted the FINOSA study to search for prognostic factors, so physiotherapists and other clinicians can screen their patients and change the rehabilitation where necessary. Thank you very much for listening. I hope you all enjoyed this talk.
Okay, Jakob, we can start with the question and answer. There are a couple of questions about this presentation. And the first one, first of all, I want to do my personal compliments for the presenters, because the topics were really high level. I think, Ingrid.
Yes, very, very good. Thank you.
Okay. You want to start with the first question?
And unfortunately, we do not have Anke class here tonight, and we have two specific physio questions. And one is regarding range of motion. And I think after this question had been posted, we got the very nice graphs from Anke. And the first question was regarding what information and how do you guide patients in the first phase. I think she also gave answers to that. And may I ask you, Olivier Verboek, what is the most important information that you want us physios to tell the patients to secure a safe path?
Yeah, so I assume you're talking about the first phase, which is the first 4 to 6 weeks.
Yes.
So I think there's an important difference between the anatomic and the reverse. In the anatomic, it's absolutely important that patients and physiotherapists understand that the subscap is usually been taken down during the surgery to dislocate the shoulder and to do the procedure and to release the contractures. That means that at the end of the procedure, the subscap is repaired in an anatomical fashion. Usually it's a good tendon, so it's a strong repair, but still it needs to be protected. And at least for 4 weeks, there is no external rotation beyond 0 degrees in my practice, and not more than 90 degrees passive elevation. This is very important. That's for the physio, but also for the patient. I always explain them that they have to wear their brace. Although they may feel well and they have no pain, they have to protect the subscapularis, because if the subscapularis fails, this is the most detrimental complication, I think, in anatomic arthroplasty. That being said, for reverse, I think it's a little bit different. Although we do repair our subscap as well, there is less tension usually, or actually there is less force involved, and usually these patients are older. And if at some point there would be a failure of the subscap, it's not that important. So I must say that I'm a little bit easier on the rehab in the reverse. But I tried to say the same thing, that we fixed it, and there was a good reason for it. And we believe it's better for the outcome, and that they have to protect it at same way. 4 weeks in a sling, and not staying in the safe zone. Which is not beyond 0 degrees of external rotation and 90 degrees of elevation.
Okay, Oliver, which means that at this point, more than ever, the team building between our orthopedics and the physiotherapist are very important for the anatomical implant, for respect and understand really when and which are the limits of subscapular repair. I have another question come on for you, Oliver. Why wouldn't go for a posterior augmented anatomic glenoid in the first case, 42 years older guys?
In the, you mean in young patients?
Yeah, the young patient.
Yeah, I mean, there's definitely a future for it. The augmented components have not been out there for a very long time. It's preliminary results, 2 to 4 years. It's promising, but you know, it's not long term. And in these very young patients, what I fear, if you do an anatomic in these bad deformities, they will fail quite fast, probably within 5 to 7 years. And then you have a revision to do in a bad situation, still not 50, and it's going to be a difficult revision. Yeah, it's really a mess. So I rather save my one and only revision, and it's going to come for sure, to a little bit later, and then to have a clean glenoids to do the reverse. But I'm sure that if augmented components show promising or better results, it will be more in my practice. That being said, I think that these type of deformities, more than 30 degrees, will be too much, I think, to resolve with an augmented base plate. I see augmented anatomic base plates or anatomic augmented in components more for patients that have deformities, let's say between 15 and 20 degrees of retro. And then that may be the future. But if it's going to be more, it's going to be problematic anyway to do an anatomic replacement.
Okay. Ingrid, will you want to start with the other questions?
So I think may I ask a question to Matisse Jackson's? You spoke about the posterior cuff, and in other work, I think that we should more and more highlight the importance of the posterior cuff, and so the cuff to balance the forward flexion. And here, do you think it would be comprehensive to make a study to really work on the rotator cuff to prevent the progression of osteoarthritis?
Oh, it's a very, very interesting topic, and it's definitely a topic that's that needs further investigation. So what we see, we don't really understand what's going on. We have some associations of the anatomy with osteoarthritis, and we see that there is some fatty infiltration. There are also studies that show that the progression of it is not really present over a couple of years, but I believe that it might be a key factor to train the posterior cuff. And as you said, it's probably an interesting topic to do a study on. Probably the OA process, you probably cannot stop it, but maybe you can put a break on it.
Thank you.
Okay, last question for Matisse. At this point, you study very well again the degenerative cuff tear, and you spoke also about the acromion. But my question is, did you find in the new lecture too if there is any relationship between mesoacromion and cuff tear degenerative or cuff tears? Because most of the times when I see patients with mesoacromion, most of the time they have massive cuff tear, and I would like to know from your experience and from your lecture too if there is any question or new studies on that.
Sorry, I didn't really understand. What did you mean, mesoacromion, or what was it called?
Not completely acromion ossification.
Oh, so more and more people believe that the ossification underneath the acromion is actually not the cause, but maybe a following of a rotator cuff tear, because it kind of tries to stabilize the proximal migration of the humeral head. So there is not a clear, there is an association between both. So you have studies that show that the ossification leads to rotator cuff tears, but it's always the chicken or the egg question, and in this case it's the same. So And more people do believe that it's actually not a cause, but a response to the whole pathology.
Okay. At this point, Ingrid, I think we have done with question and answer because we are exactly in time to give the line to Jarko and continue with the next step. What do you think, Jarko?
Yes, thank you.
Wonderful, Angelo and Ingrid. Thank you very much. There's obviously a lot of other questions. You can still ask them via the chat. And maybe we can come back to that at a later stage at some form. We now move on to the next session, and that's all on reverse shoulder arthroplasty. And I'm very honored and happy that Patrick Denard from Oregon in the United States was willing to record his presentation. Unfortunately, he cannot be here with us live, but we will share his presentation and we'll try to answer the questions you come up with from his presentation. And he will be talking about different neck shaft angles in reverse total shoulder arthroplasty. Why and how is it important? So please start Patrick's presentation.
Hey, I'm Patrick Denard from Medford, Oregon. It's a pleasure to be with you, at least virtually. I have the opportunity to talk about the evidence for humeral neck shaft angle in RSA. As you all know, there's been an evolution in reverse shoulder arthroplasty over the last several decades. Robust fixation of the glenoid, and now increasingly we're seeing a convergence of 135 lateralized designs. And I'm going to go over the evidence of why this has occurred over time. It's also interesting when you look back at some of the historical designs. One of the initial designs actually had a very anatomic neck shaft angle, but the problem was glenoid fixation. Now, to solve the issue of glenoid fixation, Paul Grammont had the clever idea to medialize the center of rotation on the glenoid base plate. That improved fixation, but then subsequently, to improve the deltoid lever arm, he had to use a 155 inlay prosthesis to gain lengthening of the deltoid. The results of this were profound because it took patients who could not raise their arm to suddenly be able to raise their arm overhead. But the problem with this type of design was that it lacked internal and external rotation. So your classic patient could get up overhead, but they could not get behind their back or out to the side very effectively. Moreover, when you look long-term, survival is high, but the vast majority of patients have notching. Many also have humeral loosening, and we see functional outcome decline over time. Needs have changed dramatically because in the 1990s and the early 2000s in the US, the goal really was for salvage, restoring forward elevation alone. But the modern needs, we have expanding indications. We're often using reverse shoulder arthroplasty in younger patients. We have greater functional demands and needs for longevity. I think it's important to think about how do we want to improve and how we try to improve over time. Well, the goal has been to improve range of motion, specifically external and internal rotation. We want to decrease polywear and decrease humeral loosening, and hopefully that will help us maintain longer function. So if we take a step back and really ask ourselves, what is the goal of reverse shoulder arthroplasty? Is it really to lengthen the arm and medialize the center of rotation? And I would submit to you that really what we're doing in the case of reverse shoulder arthroplasty, of course, of almost any indication, is to compensate for the rotator cuff. And of course, the rotator cuff provides concavity compression of the glenohumeral joint. Therefore, our goal really is to restore joint stability. And if you buy that from a philosophical standpoint, you want to be as anatomic as possible to respect the center of rotation and allow the remaining muscles to work effectively. And we'll also talk about the need for subscapularis repair. So in my mind, the goal is to really restore stability and decrease bony contact. Some more history before we move on to the actual factors for consideration. It's interesting to note that Jill Walsh learned the reverse shoulder arthroplasty under Paul Grammont, or at least was near him, and then transitioned gradually over his time to a 145 onlay prosthesis, and then ultimately ended up helping design a 135 inlay prosthesis. Mark Frankel, of course, in the US went to a 135 initially when he was using it in a salvage type of procedure and getting special approval for this. What was interesting is his story. He wanted to simply create one operation, hence his desire to make a 135 cut. And I would tell you, using a 135 lateralized design, very much philosophically, I feel like I'm doing essentially the same procedure between anatomic and reverse. So let's talk about some factors for consideration. Let's look at notching, range of motion, stability, humeral position, and tuberosity repair. If we look at notching first, Mark Frankel did the early work, and he looked at the hierarchy of implant design related factors that decrease bony impingement. And we look at the adduction deficit. Of all the factors here, the single biggest factor that decreases notching the most is moving to a more anatomic neck shaft angle. About lateralization, we compared with the 135 0 and 4 millimeters of lateralization in a series of retrospective patients. Interestingly, notching decreased in severity, but we were not able to eliminate notching with 4 millimeters of lateralization with a 135. Conversely, Mark, in his series at 2-year follow-up, with an average lateralization of 6.4 millimeters, reported no notching. What's interesting about his series, in contrast to the 155 series I showed you earlier, was he had minimal to no decline in function when he went out in his long-term follow-up study, which I'm citing here. So the notching summary is that notching decreases by moving from a 155 to a 135. Notching also decreases with lateralization, but 6 millimeters may be needed in most cases to remove notching. What about range of motion? If we go back to Mark Frankel's work, in his evaluation, range of motion was improved most significantly by glenoid-sided lateralization because this took impingement away from the glenoid. What are the computer simulation studies here? A couple of studies have looked at this. Both of these studies concluded in a computer simulation model that 135 and 5 to 10 degrees of lateralization provided the best range of motion. The clinical evidence also supports this. Systematic review comparing 155 to 135, 3-year follow-up. We see that forward elevation is similar between groups, but external rotation is improved with the 135 compared to 155, probably because more lateralization was used in the 135 group. We looked at lateralization specifically, comparing out to 8 millimeters of lateralization, a series of 455 patients. And we noted that internal rotation was improved when we used 6 to 8 millimeters of lateralization with a 135 prosthesis compared to 4 millimeters or less, as is shown here. So the clinical evidence suggests that 6 to 8 millimeters of lateralization improves internal rotation. Now, some people talk about humeral lateralization. This is an interesting recent study from one of the Exact Tech groups, 130 RSAs. They found no relationship between humeral lateralization and functional outcomes, as you can see here. So this is a classic example of what I try to achieve. 72-year-old gentleman, inability to hold his gun. We've used 8 millimeters of lateralization, and you can see that he has good forward elevation overhead. This is 2 years post-operatively. He's not perfect, but his internal rotation is functional, getting to his belt line behind his back. So the summary here is there's no difference in forward flexion based on neck shaft angle. External rotation is improved with the 135, probably related to lateralization. We can also see that with internal rotation as well. And both simulation and clinical data suggest that rotation is improved with glenoid-sided lateralization, which typically goes along with a 135 prosthesis. Now, in terms of stability, what do we have? Well, we know that stability can be affected by subscapularis repair. Brad Edwards' classic study, they had dislocations that was higher in the irreparable group. Of course, this is a mixed series, and there were several factors for that. Another series here, primarily 155s, it was a mixed series. Subscapularis repair was associated with stability. Tony Romeo's study of 385 RSAs, mostly 145 onlays, they had a higher rate of irreparable or poor subscapularis tendons when they had dislocation. What about 135 here? Actually, with a 135 based on this study from Hawkins group, no difference in dislocation based on whether or not there was done a repair. The systematic review evidence If you look at dislocation with and without repair, it's higher without repair. However, the biggest difference is with a medialized design. So with no subscap repair, it appears that lateralized implants can be okay. But biomechanically, regardless of the neck shaft angle, as Tylene has shown, subscapularis load increases the force to dislocation. Another paper here looking at functional outcomes, subscapularis repair tended to result in some slightly improved outcomes, as you can see here, not dramatic differences. Our study of 135s, we found that when the subscap was torn preoperatively, we had lower internal rotation postoperatively. And finally, Philippe Callan has demonstrated to us that subscapularis healing improves internal rotation postoperatively. Summary here then, subscapularis repair improves biomechanical stability. Clinically, the importance of dislocation, however, is larger with lower neck shaft angles. It appears less important with a 135, but I think it's important to remember that subscapularis healing appears to improve outcomes, and that's easier to do when you have a more anatomic position. What about humeral position with 155? Many of us saw this poor deltoid contour, and it's important to also recognize the difference between an inlay and an onlay, because an onlay distalizes the subscap and makes it difficult to repair. This is most common with a 145 prosthesis. If you look at the anatomic position, the most anatomic RSA is a 135 inlay design, which is demonstrated here. And we see, comparing one of my early patients, 155 medialized design to a 135, we have no notching and a much different appearance of the deltoid contour post-operatively. Although these are different patients, I think it's easy to tell the difference, as you can see across the board. This is another interesting patient that came to me who had a 145 onlay on one side, a 135 inlay for revision on the other side. The onlay was done 7 years ago. She had done well, but then lost function on the right due to deltoid rupture late in her recovery. What about the rate of complications? The rate of complications appear to be higher with less anatomic designs. This study that we did of 426 RSAs, we found with a 145 onlay, the fracture rate was 3 times higher compared to a 135 inlay post-operatively. Interestingly, the difference with the acromial distance was only 4 millimeters in this study, which is important to remember. I'll show you some other work subsequently that echoes that. Others have also found the same thing, that when you lengthen the arm, which occurs more with more horizontal neck shaft angles, you would increase the risk of acromial stress fracture. Neurological injury has also been reported to be more common with distalization, which again occurs with more 155 and 145 compared to 135 designs. This study out of Korea, acromial distance was increased in the neurologically injured patients. And again, it was only a 4 millimeter difference. So the humeral position summary is that distalization increases the risk of inability to repair the subscapularis, stress fracture, and nerve injury. Finally, let's move on to tuberosity repair in the fracture setting. We know that tuberosity healing improves functional outcomes. This has been shown in several studies as well as systematic review, as we have seen here. We looked at tuberosity healing according to humeral neck shaft angle in a systematic review of 873 patients. In this series, we found that healing was highest when we had a 135 prosthesis. It was 83%, and you can see much lower, only 66% with a 155. So the tuberosity repair summary is that tuberosity healing improves functional outcomes after RSA for fracture, and healing is highest with a 135. So when we summarize all the evidence of 135 versus 145 or 155, we see that notching is decreased with 135. Range of motion appears to favor 135, specifically when you compare it to 155. Stability and subscap repair favors 135. Complications appear to be reduced when we have less distalization, as you would see with the 135. And tuberosity healing is highest with the 135 prosthesis. So I think the evidence is clear that it supports a 135 RSA in the modern era. Thank you for your attention. Very much enjoyed the opportunity to present to you today.
Thank you very much. Patrick will not hear us, but I think he did a wonderful job in giving us this very clear and nice structured overview of the different neck shaft angles and their advantages and disadvantages. The next speaker, it was already addressed in the previous talk, talked about lateralization, and we're talking about lateralization of the center of rotation in the reverse. Hannon McMullen, everybody knows you because you organized SECEC last year, 2022 in Dublin, which was together with Ruth Delaney, which was a wonderful meeting. And Hannon has also a lot of experience with also using the DJO prosthesis, which already was mentioned, which Mark Frankel designed. So really looking forward to Hannon's presentation on how do we do the lateralization. We either use bone or metallic, and why.
Good evening and greetings from Dublin. I'd like to thank Jarko and all the SECEC team for their kind invitation to speak at this fantastic webinar. I am a shoulder surgeon in Dublin and work in a number of hospitals, including the Sports Surgery Clinic. And I'm going to talk this evening about bony and metallic lateralization in reverse geometry shoulder replacement. The history and evolution of lateralization, the advantages, various options available, and results. By disclosure, I'm a consultant for Novus. And interestingly, when we look at the history of reverse geometry shoulder replacement, it started with a lateralized fixed glenoid component. But however, there was a high rate of glenoid loosening and a high complication rate, and this was abandoned. The Grammont-style prosthesis involved medialization of the center of rotation by a medialized glenosphere, and this led to a lower failure rate compared to its predecessors. And although the Grammont-style prosthesis had a lower overall failure rate, there were issues with scapular notching, excessive distalization leading to neurological sequelae, slackness of the posterior cuff causing weakness of it, particularly in external rotation, and instability. And the rate of scapular notching was noted to be quite high in several published series. And although originally felt to be quite a benign issue, we now know that scapular notching can be progressive and lead to failure of the prosthesis. Slackness of the posterior rotator cuff can also lead to weakness and loss of external rotation range with a Grammont-style prosthesis. Patients may also find the altered shoulder contour following a Grammont-style prosthesis to be cosmetically unappealing. Another negative aspect of the Grammont-style prosthesis is a relatively high rate of instability. Reverse geometry shoulder replacement design has evolved to overcome these issues with features on the glenoid side, such as increasing glenoid size, eccentricity, and lateralization of central rotation, and also other features on the humeral side, which I'll come to. The advantages of lateralization include decreased scapular notching, improved impingement-free range of motion, increased rotational strength, improved shoulder contour, and improved stability. Lateralization can take place on the glenoid side or on the humeral side, or with combinations of both. So if we take the Grammont-style prosthesis as having a medial glenoid and a medial humerus, lateralization can occur by lateralizing the glenoid and not the humerus, or lateralizing the humerus and not the glenoid, or through a combination of both, with both lateralization on the glenoid and humeral side. So if we look at lateralization on the glenoid side, this can be through a lateralized base plate, a lateralized glenosphere, or in fact using a bone graft, i.e. a bio-RSA, where a segment of the humeral head is used to lateralize the glenosphere. The advantage of the prosthetic lateralization is that it's a straightforward procedure. There's the ability to trial various lateral offsets. In the earlier designs, there was an issue with base plate failure due to increased base plate shear forces, though this has been overcome due to various design modifications, including locking screws. The main disadvantages of biological lateralization is that it's complicated. There's increased time in the operating room. You need to have the native humeral head, so not helpful in a revision case. There may be failure of bone incorporation. And of course, you don't have the ability to trial that you have with a metallic implant. Humeral lateralization can be achieved by changing the neck shaft angle, the use of either inlay or onlay humeral components, and other features such as the shape of the stem. And the effect of moving from a neck shaft angle of 155, which would be typical of a Grammont style prosthesis, to 135 is to significantly reduce scapular notching and to improve adduction. The other feature of changing the neck shaft angle is to affect lateralization of the humeral component. And in this case, you can see that as we move from a 150 neck shaft angle to a 130, there is an approximately 7 millimeter difference in the lateralization. And the humeral component can be either an inlay type device in this case, or an onlay device, which leads to greater lateralization. Advantages of the inlay device are that it's more anatomical, you get less humeral lengthening, improved shoulder contour, and generally it's easier to repair the subscapularis. The advantages of the onlay technique is it preserves proximal humeral bone, possibly easier to convert, and improve deltoid wrap. And this interesting study by Werthel et al. Looks at the current available prosthesis designs, and the red line, the vertical red line, shows the lateralization of 13.1 millimeter from a Grammont Delta 3. And then if we look in the orange, we can see the glenoid offset, the blue being a humeral offset, and then the yellow being the maximal additional offset in use in terms of use of other components or biological augments. And there's a large variation with a range from the Grammont of 13.1 millimeters to the most lateralized being 35.8 millimeters. And we can see here the significant difference in lateralization between the minimally lateralized Grammont Delta 3 style prosthesis and the maximally lateralized prosthesis, where we have lateralization of the glenosphere through both the base plate and the glenosphere, and also a lateralized humeral component with an onlay device. Frankel's group have looked at the adduction deficit and looked at the hierarchy in terms of what contributes most to the improvement in the adduction deficit, looking at various configurations. And they've established that the hierarchy is that number one, in fact, is on the humeral neck shaft angle of 130 degrees, which is superior to the effect of an inferior base plate position, which is in fact greater than a lateralized center of rotation of the glenoid. Frankel's group also looked at the range of impingement-free motion after reverse geometry shoulder replacement, and again looked at the hierarchy of surgical and implant design related factors. And for this outcome, they found that in terms of the hierarchy, number one was the center of rotation and the glenoid offset. Number two was the glenosphere position. Number three, glenosphere tilt. Number four, humeral neck shaft angle. And number five, prosthetic design. Frankel's group in another paper looked at the effect of component design and surgical techniques to restore glenohumeral motion. And their conclusion was that 10 millimeter laterally offset glenosphere provides the greatest range of motion in all planes, but that the neck shaft glenoid position may be further adjusted to optimize single plane motion. And when they looked into single plane motion, they found for abduction, the optimum construct was a valgus humerus, so 150 cut humerus with an inferior glenosphere 42 millimeters. And looking again at flexion extension, the optimum was 130 degrees varus cut with a 36 millimeter glenosphere. And finally, looking at internal and external rotation, again using a center of rotation lateralized glenosphere, 42 millimeter glenosphere, and a 130 degree humeral cut. We've noted with some component designs with both a lateralized glenosphere and a lateralized onlay humeral component, it's possible to lateralize by 35 or 40 millimeters, and it is possible to have too much of a good thing. And there is data suggests that with the increased lateralization, there is increased risk of a acromial stress fracture. There may be overstuffing leading to stiffness, and in some cases, particularly smaller patients, it may lead to neuropraxia and other unwelcome consequences. So in summary, lateralization and reverse geometry shoulder replacement has led to reduced notching, increased stability, better external rotation strength, and improved shoulder contour. Lateralization, as I mentioned, can be achieved through either lateralization on the glenoid side, humeral side, or a combination of both. It's important to be aware of the preoperative limitations of range of motion that your patient has, and to be aware of other factors such as thoracic kyphosis, and to be aware of possible overlateralization, particularly in the smaller patient. It's been a great pleasure and privilege to be involved in this fantastic webinar. Again, thanks to Charcoal, thanks to all the SECEC team, thanks to Silvio, who's working behind the scenes here to make everything happen. And I hope you enjoy the rest of the evening.
Thank you very much, Henning. Wonderful talk, very interesting. Nice picture ending at the coastline of Ireland. The next talk will be by Matthias Zungstein. We move over to Switzerland, and Matthias is been doing a lot of work, because it was already mentioned by Olivier that navigation can help us in the car, but it can also help us by optimally placing the prosthesis. And Matthias has already a lot of experience with placing the reverse prosthesis using navigation. So he will enlighten us on this topic and show us how he does it in this next presentation.
Good evening, ladies and gentlemen. I speak the role of navigation in the reverse total shoulder arthroplasty. These are my disclosures, and of course, they're relevant to this talk. The schedule is pretty close. So what is virtual mixed and augmented reality, including navigation, how I plan and how I execute, and how is our cadaveric and clinical data personal, but also what is out there in the literature. So virtual reality is fully artificial. It's good for simulation, learning, and teaching, but it does not have a directly real world in it. Conversely, mixed reality is the transfer of some virtual objects in the real world, usually with goggles, but you have not the potential to interoperatively interact. Conversely, augmented reality is an overlay of that objects, but you may have the potential to interact directly during the surgical procedure, so it increases safety and reduces complications. Navigation is a technology which creates a 3D virtual model out of the patient's anatomy, and it guides you as a surgeon during the surgical procedure, and you have a real-time feedback on the location of your instruments and on your components. So what I do is I use navigation and augmented reality combined to have really, during the surgical procedure, an interaction with the planning. I use a camera and a tracker, and of course a control unit and some glasses are optional in order to improve visualization. This is the flow chart. You have to upload your CT scan, and within 24 to 48 hours, you get a planning, and you transfer via USB stick your planning into the OR, and you have during the surgical procedure feedback. So how do I plan? First, we have to understand that the workload of the data when you upload it is first segmentation. And then the question is it manual, automatic, or automatic with manual correction? How is the gold standard and replication? Then second step, what are the anatomical landmarks, like the coracoid tip, like the superior border of the glenoid, like the trigonum, like the inferior border, and then you can define the parameters like inclination, version, or whatever. And all of those parameters is important to know the reproducibility and the observer agreement and also the method agreement. Before we plan, we have to understand that most of our data is based on a 46 head. Pascal and Jill has done this great paper in 1997, where they showed that the most of the patients have a 46 diameter of the curvature, which is signed here. And then the mean medial offset was 7 millimeters. And that's why you have an anatomic lateral offset from the GT to the stem of 16.2 millimeters, meaning that if you have a 46 head diameter with divided by 2, 7 millimeter offset, then the distance from the stem blue towards the bone is 30 millimeters. So not every shoulder is the same. My shoulder is not the same like yours. So I calculate always individually this lateral offset, because in smaller patients, you have to lateralize less in order to be completely anatomic compared to bigger guys and bigger shoulders. So for example, here the total lateral offset is 28, the distance from the stem to the glenoid. And that's why I know my prosthesis details. So my humeral lateral offset of the prosthesis is 9.2. So I know 28 I have to be at the end. 9.2 is the humerals. 14.3 is the glenoid. So 28 minus 9.2 minus 14.3. And I read 2 millimeters here medially, which needs a trapezoidal graft of 6.5 in order to be exactly at the same position as preoperatively anatomically in terms of lateralization. That's give me this planning of a graft on that three-dimensional planning, which I know I correct the retroversion, the inclination, and I read 2 millimeters. Additionally, I can plan how much I want to distalize and, of course, lateralize, because I know if I distalize too much, there is a negative predictive value that you may decrease the function because you over-tension the joint. And if you lateralize too much, you may have some problems to refixing the subscap. So this is then my completely finalized planning three-dimensionally with this bone graft to be anatomic in the medial lateral extension. And then what is execution with augmented reality and navigation? First, as we heard, you need to have trackers and a camera. So you have to fix the tracker holder on the coracoid. Proper orientation here is the key, that you see each other during the surgical procedure with the camera and the tracker. Then you give a rough orientation of the glenoid space, including definition of 4 points: posterior, superiorly, anterior, and inferior. And after that, you define 20 points on the glenoid as well as on the coracoid in order to precisely match the bony surface of the patient's anatomy with your system. Then you can start to operate, including this augmented reality and navigation. And you see if I'm not perfectly in line with the K-wire here, the system will show it to me and I have to correct it. Furthermore, it shows me that how is my inclination and retroversion. Always the green one is the planned one, the blue one is my effective one. So I have direct and intraoperative feedback, how precise I am compared to the preoperative planning. Then the same for the reaming. I know that if I ream, how deep I can ream, how again on my retroversion and the inclination angles, and then the central post for the retroversion as well as the inclination, if I'm really correctly compared to the preoperative planning in green. You see it below on the screen. Then you prepare your bone block, as we already heard, with this instrument that you're precisely exactly like the preoperative medial lateralized anatomy. And then you implant the bone block with the glenosphere. And again, you have there control of your depth, rotation, retroversion, and inclination compared to the preoperative planning. After this is one of the greatest things, the screws I see directly in my bone where the screws will go in the screen during the procedure. And then I position the glenosphere, correct the rotation as you might see here, and fix it with the screw. So this is the postoperative X-ray of that patient. And the question is now, are we really precise with that system? First, we've done a cadaveric study and we looked for the deviation, planned, intra, and postoperative for the parameters, as we heard, inclination, version, entry point, and rotation. And you see it's an overlap of the preoperative planning and the postoperative CT scan in those cadavers. And interestingly, we were really precise. In terms of inclination, we planned 3.2 and we had just a deviation of 1 degree. And you say all the parameters, retro, depth, entry point, as well as rotation, we were below 2 degrees or below 2 millimeters. Now we want to transfer this to the clinical data, and we operated 42 patients. 39 was possible because we had at the beginning a problem with the system in 3 cases. Cuffed arthropathy, the main cohort. So the preoperative version we corrected to 2 from 9, the glenoid inclination always to 0. We had a reaming depth of 7 millimeters and a mean lateralization of 7 millimeters to be anatomic. The DSA was 71 and the LSA was 65 preoperatively planned, and we had 2 complications, 2 fractures of the coracoid. Twice we had to change the program in a subscap arm approach. The total registry time was 6.5 minutes, 3 minutes for coracoid track replacement and 3 minutes for calibration, and the total surgical time was 2 hours. If we look now to the radiographic data, then we show that the inclination from planned to intraoperatively changed not that much. Conversely, lateralization was a little bit higher compared to our planning. But what is then important, if we decided intraoperatively we want to do it like this is, and if the postoperative CT scan shows us how precise we were really precise. The biggest deviation was 2.2 degrees of retroversion. All the other parameters, either key wire positioning and lateralization, were below 2 millimeters or 2 degrees. So intra to postoperatively, which I think is the most important message, is really precise. This has been shown also by other authors. Regarding the LSA and DSA, the deviation was low. However, we were not always perfectly as we have planned, maybe because the planning was 3-dimensionally and the post-op control was on the X-ray. So as a take-home message, you have to understand that augmented, mixed, and virtual reality are not the same. Navigation gives an intraoperative control and interaction. In both cadaveric and clinical study, you can be really precise with a deviation below 2.2 degrees and 2 millimeters between intra and post-operatively. Thank you very much for your attention.
Thank you very much, Matthias. Stay in the car narrative. It's always with you, fasten your seatbelts because you go very fast, but you tell a lot of interesting things. Thanks for sharing. And now you've seen wonderful ways to put all new reversers, different positions, and how put them in. But now the final question, obviously, Solange, is how how we'll be doing the rehab after a reverse prosthesis. So Len Gain, I'm very happy that you're here. You're from France, and you're doing a lot of work on rehab after reverse and anatomical shoulder prosthesis. And you will share in your presentation how we need to rehab after reverse prosthesis. Thank you very much.
I'm Solène Gain, shoulder physiotherapist in France. I'm the vice chair of Network Communication Committee of EUSSER and the French national delegate. I'm also working with Philippe Collin, shoulder surgeon in Paris, and I will talk about 2 of our clinical studies. I'm happy to talk about rehabilitation after reverse total shoulder arthroplasty and the role of the scapula. We have to aim high for these patients because there are good results after reverse shoulder arthroplasty. The main goal is to have a painless and functional shoulder. Active anterior elevation recovery is good, but a little bit lesser than anatomic prosthesis. Active external rotation recovery depends on the presence of posterior rotator cuff, and active medial rotation recovery is often incomplete or takes longer time. Our first clinical study is about factors influencing the recovery of range of motion following reverse shoulder arthroplasty. To analyze active anterior elevation recovery, we separated patients into 2 groups. Group 1, the patients who had an active anterior elevation recovery under 90 degrees at 1 year. And the second group, group 2, who had an active anterior elevation recovery above 90 degrees at 1 year. If we look at passive and active anterior elevation range of motion after surgery, we can see that the difference between the 2 groups begins very early after surgery, and at 6 weeks, there is a big difference between group 1 and group 2. So, predictive factors for a good active anterior elevation recovery should be a fast recovery of passive mobility and a fast recovery of active anterior elevation mobility. It's important to have an early identification of patients with deltoid weakness, and it's important also to improve passive mobility very early after surgery. In our study, the preoperative unfavorable factors for active anterior elevation recovery were non-dominant side, preoperative low subjective score, preoperative low active anterior elevation. Perhaps there are neuromotor aspects because there was patient with poor upper limb representation and poor use of the upper limb before surgery. We have to focus in rehabilitation on neuromotor aspects to have an active mobility recovery optimization. The goal of the rehabilitation is to recover the functionality of the upper limb. The biomechanical characteristics of reverse shoulder arthroplasty are very specific. First, there is the importance of the scapulothoracic. There is more use of the scapulothoracic in the reverse shoulder arthroplasty compared to the normal contralateral shoulder. And the significant difference is for upward rotation. So we have to focus on improving upward rotation in rehabilitation. In rehabilitation, we have to improve scapulothoracic mobility. We have to improve passive mobility of the scapulothoracic passive mobility depends on muscles extensibility, pectoralis minor, rhomboids. So we have to stretch these muscles. And it depends on acromoclavicular mobility, sternocostoclavicular mobility, and mobility of the thoracic spine. So we have to improve the mobility of these joints. We have also to improve active mobility of the scapula and to activate serratus anterior and trapezius. The second important characteristic of reverse shoulder arthroplasty is the deltoid. This is the key muscle of the reverse shoulder arthroplasty. Anterior and posterior deltoid are recruited as abductors. And there is also an increased EMG activity in the deltoid muscle compared to the LC group control. So we have to focus also on deltoid strengthening during rehabilitation. So what are the physiotherapy guidelines? If we look at systematic reviews, there is no consensus about physiotherapy after reverse shoulder arthroplasty. And there is a need of more studies based on clinical outcomes. One study compared early rehabilitation to delayed rehabilitation after 6 weeks. There is no difference between the two groups. But we think early rehabilitation is positive for the patient. It can improve patient involvement in rehabilitation. It can improve deltoid activation, and it can help the patient in daily activities. So in our protocol, we begin rehabilitation very early, the day after surgery, and the patient can do active assisted exercises. This is a proposal for physiotherapy guideline after reverse shoulder arthroplasty. Phase 1 is the first 3 weeks. The goal of this phase is to recover global passive elevation, passive range of motion, and active assisted range of motion. In the second phase, from 3 weeks to 6 weeks, the goal is to recover active elevation and rotations. And we can begin a progressive deltoid activation program. The third phase is a strengthening phase from 6 weeks to 3 months. And we can begin a strengthening muscles training for deltoid and scapular muscles. Remember, we have to focus on functional. We can add neuromotor elements in our rehabilitation, like bilateral movements, the importance of the hand during exercises, and the visions. And we have to activate motor muscles of the scapula, and we can use kinetic chain to improve the activation of the muscles of the scapula. This is an example for the progressive deltoid strengthening program. And this is the first step of the program. This is place and hold in high position. Then the patient can do other exercises like arm-supported exercises. And we can work in a high position to activate also muscles of the scapula, like here, serratus anterior. In progression, we can add elastic band for the patient. We have to improve endurance, strength, speed, and we can use kinetic chain and use neuromotor rehabilitation. This is our second clinical study. It's about active internal rotation recovery in the functional movement and to the back. We observed 3 types of patient. Type 1, the patient is able to put his hand to bottom sacrum. Type 2, the patient is able to put the hand up to lumbar spine. And type 3, the patient is able to put the hand up to thoracic spine. We divided the patients in 2 groups. Type 1, buttock sacrum, this is not functional for the patient. And type 2 and 3, lumbar and thoracic spine, this is functional for the patients. We assessed active anterior tilt of scapula with a digital inclinometer. We assessed passive internal rotation in position 2 with a digital inclinometer 2. And there was ultrasound for the subscapular wrist to know if it's healed or not. In conclusion, there is a statistical link between functional internal rotation, type 2 and 3, and the subscapular wrist healed. We have to protect it in early phase in rehabilitation. Better passive internal rotation in position 2, we have to make it more flexible, and also a better active scapular anterior tilt, we have to improve it. For a good functional recovery, it's important to have patient involvement in rehabilitation. We have really to focus on scapular mobility, on upward rotation of the scapula for active anterior elevation, and anterior tilt of the scapula for active internal rotation. We have to do strengthening of the deltoid and serratus anterior and trapezius, and it's very important to do a neuromotor rehabilitations too. Thank you for your attention.
So thank you very much for this nice presentation. I think we had a great session about the reverse arthroplasty. Thanks to all the speakers for their great talks. So far I can see only 1 question we have.
Yeah, there were a few questions, Christian, from the previous. There was one question about where to put the guide wire for the anatomic versus the reverse. I think Hannon's and Matthias' talk has made it clear. We tried to have an inferior placement of the reverse glenoid, but those have been answered, I think, in the talks. There was one question about where to check the level of retroversion. Matthias, do you want to take that question?
Yeah, sure. So the level of retroversion, I think in 2D, the standard way to do it is using the Friedman line just beneath the coracoid as described by Rulo. There are surgeons that actually don't use it, then go more inferiorly because the pathoanatomy is more severe inferior to that section. So it can be discussed which slides you use. In 3D, you have a more, so this is the power of 3D, you have a more general overview of the whole pathoanatomy, but here it's important to know that different softwares we use that have a different way to assess it. So you have software that use 3 points, at the superior point to at the inferior point, making a general plane, or you have the ones that use a best fit sphere, or then you also have the ones that use the complete articular surface to measure or create the best fit plane. So in 3D, you have in theory the best option to have a more general overview, but you have to keep in mind what you're actually doing, what your software is doing. In 2D, you probably have to go to the inferior section of the glenoid where the pathoanatomy is the most severe.
And I think there was a bit of mix-up between the names. So this was Matthijs. And I think the question was to Matthias.
Oh, I'm sorry.
Matthias, maybe you could answer this question as well.
He's answered that very well. Well, there is a question from Matthias. Matthias, you mentioned about the learning curve for doing the intraoperative navigation, and in your study you showed about 6 minutes. But there must be a learning curve to it. When you initially started, was it 6 minutes, or do you spend more time doing the tracking?
Yes,
Thank you very much for the question, for that question. At the beginning, that was the mean time for putting the tracker and also for the navigation over the first 42 cases. We've done 5 cases proof of principle, and then we start the consecutive series. Of course, at the beginning you had 8-7 minutes, and then you decrease it to 4 or 5 minutes. Now you're getting quicker and quicker. And so far, we are at the level that the registration process would be faster than we are as surgeons are there to finding the points. So we have always to hide. So I think technology is really great, but we are could not be much faster than 3-4 minutes in order to have this everything just for this step of the registration and the calibration.
Are you using navigation for every case in your setup?
Thank you very much, Shagwan. That's a very important question. No, of course, that was just because of a study. We wanted to be sure that we are precise as precise as we expected, but absolutely clear that I do not think that navigation is needed for every case. But we started to do a consecutive series, included all reverses, but I'm absolutely agree with you that it's not necessary in all cases, but it needs to. It's a really, really great tool, especially in high retroverted patients or great used glenoids where you do not have many shots, or meaning just one shot in order to be correct or precise.
Thank you.
Just to follow up on you, Matthias, could you just give a short note about the costs of the implant? What's the difference between your...
Yes.
Okay.
So the only thing what you have, it's a single-use tracker and a camera. This is, I think, dependent on the country. It costs about a couple of $100 for both. All the rest is there, and the company will provide it. I guess it's independent which company do you use. And for every surgery, you just need to have the tracker and the camera.
Perfect. Thank you.
And of course, excuse me, I forget something. Of course, the CT scan, I use always CT scan to plan, and a 3-dimensional planning is also needed. On a couple of $100 for the camera and the tracker, but the CT scan, of course, but I think most of us do a CT scan for plan.
Thank you.
Solène Gain in her talk mentioned a very nice talk, so I must compliment you. So you mentioned about the AC mobility and the sternoclavicular mobility. Do you see that there is any protective effect of AC excision on acromial stress fractures? Anybody in the panel who's noted there have been papers coming out that AC joint excision does prevent against acromial stress fractures in the long term?
I think you're still on mute.
Sorry. Thank you for your question. I don't know really, I don't have the data for this, but it's very important to have a good motion of acromoclavicular joint because of the scapula, because you look that it's very important to improve upward rotation.
Thank you.
Can I ask Solène, because we mentioned Patrick Denard, he isn't here, so maybe we can ask a question from his presentation to you. He showed that the different neck shaft angles, eventually probably 135, will give a more optimal range of motion. Do you have in your experience already any sight on if there's a neck shaft angle 155 or 135, that those patients in your hands during the rehab process are doing easier or better, or don't you have that experience yet because you haven't seen it yet?
Yes, I agreed with Patrick Denard, and I think we can have a good result for range of motion, just a little bit lesser than anatomic, but we have a lot of patients with 160 degrees of forward flexion. So it's not 170 or 180, but around 150 degrees. So it's a very good result for these patients.
There was a question for Sven about the age limit for the stemless.
This is a question for me.
No, for Sven, sorry.
Sven, you're still on mute, Sven, I think.
Sven is, oh, I'll message him now.
I think he left, Sven.
No, he's still here. He's talking. He's also called charcoal all the time, but he's talking.
He's talking, yeah.
But we can't hear you, Sven. Sorry. No. Sorry. We need to read your lips. In the meantime, maybe we can ask a question to Hannon. You showed us the difference between bony and metallic lateralization. And what I was curious is what's your personal favorite? What's your or personal preference to do so? Bony or lateral?
Yeah, my preference is to use the metallic lateralization. I think with the options that you have in terms of augments, it's simpler in the operating room, and also, as I mentioned, it's easier to trial. It's difficult with the biological augment, although it's quite an elegant and like a green option. It's less easy on the table to trial it. And I think the incorporation rate is high, but it's not 100%. So I think metal is a little bit more reliable and takes an element of the
Charcoal, can you hear me now?
Yes.
Yeah. I don't know.
Sorry, Sven. It's not going to happen tonight. Unfortunately. We need to do it another time with a drink or something. Angelo.
I answered written. I typed it in.
Thank you.
So there's one question from Angelo.
Yes, Angelo has a question.
Yes, I have a question for Matthias. If you have any experience with your navigation system with patients without coracoid after letter J procedure, how can you manage that kind of cases? I mean, you can put the pins on acromion or what?
Yeah. So thank you very much for that question. Honestly, answer is I've never had a patient so far without the coracoid, but what we're working on another project for lateral navigation. So what is possible that you put only one pin directly in the base of the coracoid. What I do with the tracker pin, I place them also, if you have the coracoid like this, I place them directly in the base of the coracoid until the neck of the glenoid. So anyhow, I'm really, really much within the shaft of the coracoid and the base of the coracoid. So I think it should be possible. Also, just with one pin, Alex Lederman, who was part of that study, he does just one pin. But the honest answer is I've never had this case.
Thank you very much, everyone.
Yeah, I think considering that we are going to. Excuse me?
End your question.
Excuse me? No, okay. I'm saying that I think that we as a surgeon, we should consider all these cases because it's not really often. I mean, we saw cases with arthrosis after letter J procedure, and most of the times have a very big defect, and we need the help and support of the navigation system. Thanks a lot for the answer, Matthias.
Thank you very much, everyone. It's already near 10:15, and there's still over 100 participants left joining us here at the SECEC webinar. So there's probably a lot to talk about, and it's interesting, has been very interesting information which has been shared. As a note, this webinar is being recorded, so within a few weeks, all this information you can see in a replay either on the SECEC website or on the user website. And with this, I would really like to thank the panel again, all the presenters for all their effort they put in. And I would like to wish you a very happy evening and hope to see you somewhere in the flesh again and join this discussion. Thank you very much. Bye-bye. Have a nice evening.
Thank you, everyone. Bye-bye.
Bye-bye. Thank you.
Bye-bye.
Perfect, everyone. Thank you.
Thank you, Ingrid. That was really nice.
Thank you, Chakra, for the perfect organization. Well done.
Thank you.